Thanks a lot. So we're going to talk a little bit today about transitions between pharmacotherapies for opioid use disorder, specifically methadone to Suboxone. And this is a really important topic. As Suboxone is becoming more available and more people are getting sort of used to using it, I think it's really important that we're all as familiar as possible with how to transition people, because often people aren't able to get started on it initially, but then once they're on another OAT like methadone, they eventually want to transition to it. So we can go to the next slide, please. Just funding acknowledgement. Next slide. So I have no financial disclosures, no ties with industry with Suboxone manufacturer. I'll try and just say buprenorphine, not Suboxone, but sometimes I may slip up. I get a small honorarium from the BCCSU and get paid through the health authority and fee for service for clinical work. But that's it. No disclosure of commercial support. Opioid use disorders received financial support from Health Canada SUOP grant and from the BCCSU, but no industry supports. All content's been reviewed for bias, and it's been validated by the planning committee and approved for accreditation has been submitted. So we're going to talk a little bit about reasons people may want to transition from methadone to buprenorphine, and how to safely and effectively transition a patient. We're going to talk about a few different ways, but there's one way sort of that most people are doing it now, what some people have referred to as microdosing. So we'll talk about that. We'll talk about some of the different strategies and talk about a care plan for this transition. And we'll talk a little bit about office-based and laboratory tests, urine drug screening to aid in the transition from methadone to buprenorphine. So just a very brief review of oral opioid agonist treatment options. So these are the three main medications that we use to treat opioid addiction, and they're collectively referred to as OAT. Buprenorphine naloxone is the first one. So it's important to understand a couple main pharmacologic properties of this. Number one, it's a partial agonist, which means it partially activates the opioid receptor. And this is in contrast to full agonists such as methadone or morphine, or almost all other opioids that we think of traditionally as opioids like fentanyl and heroin and oxycodone and hydromorph are all full agonists. The other important pharmacologic characteristic, which it doesn't specifically say here actually on the list, I think it reviews it later, is that it has a very high binding affinity. It sticks to the opioid receptor very strongly. And so that'll be really important for understanding why we're doing certain things. And really, I think the crux of this talk is really to understand those 2 points. And when we're making the transition, understand the action of those 2 points as we transition. So the other really important part about buprenorphine is it has a much superior safety profile. It's very difficult to cause overdose with buprenorphine. And in fact, there's some evidence that it's protective against opioid overdose. Many people think it has a milder side effect profile. And because it's much safer, it's much easier to have take-home doses much more quickly, to have home inductions, that kind of thing. And so that's really important. It's also important to know that naloxone is not active at all in buprenorphine, in the buprenorphine naloxone by dual compound when it's taken sublingually. And the only reason naloxone is in the compound is to discourage injection or other forms of abuse, which will cause you to go into withdrawal. So methadone, probably many people are a bit more familiar with if they've been in practice or prescribing opioid treatment for a long time. It's a full agonist, has much higher risk of overdose, more side effects for many people, and it's usually daily witnessed ingestion with take-home doses requiring not using and 12 weeks of negative urine drug screens. Slow-release oral morphine is the newest kid on the block. It's also a full agonist. It's basically just morphine that's released slowly over 24 hours. The brand name is Cadian. And that is almost always daily witness ingestion. There are very occasionally people who have take-home doses, but they need to have very long periods of stability. The guidelines say 16 weeks of negative urine drug screens, and in practice, it's often longer than that. Okay, next slide, please. So we're going to be talking about the indications for transition. So why would you want to transition between methadone and buprenorphine? So one reason is if methadone is not effective. So people are using non-prescribed opioids, continuing or increasing their use. Other factors include wanting lower barriers to take-home doses, wanting to have fewer drug interactions if you're on lots of different drug interactions, wanting to have less impacts on certain, related to certain medical conditions like cardiac conditions. People sometimes develop cardiac conditions, which makes methadone not an ideal choice, particularly if they have a prolonged QTC. And so those are some of the main reasons. I mean, patient preference for buprenorphine is also a reason. So the last point under transitioning to buprenorphine, insufficient amelioration of cravings and withdrawal symptoms for full 24 hours with methadone. So buprenorphine does often last a little bit longer than methadone, but in general, if someone's cravings aren't ameliorated on a sufficiently high dose of methadone, it's unlikely that they'll be significantly better dealt with with buprenorphine. But sometimes it's worth a try, especially if Cadian has already been tried as well too. And so the final point, just any transition should really be done as a sort of a team effort, right? I always talk to patients about, your treatment with OAT is really a team effort, right? You know yourself better, you're an expert in yourself. I have experience treating hundreds of patients with this medication. So I know the medications quite well, and I know the trajectory of this illness fairly well, but I don't know you as well as you do. So really thinking of it as a team is really important that I try and tell people about. Next slide, please. So considerations for transitioning between opioid agonist treatment options. So really understanding the patient well and ensuring the patient understands the treatment is really important, really understanding the patient's goals, and considering the treatment plan in terms of everything else that's going on. So generally transitions are somewhat rockier than being on a stable dose. And so it's good to have these transitions happen at a time when as many other things are as stable as possible, if possible. Obviously working closely with pharmacists is really important. The preferred method now is for buprenorphine transition is microinduction. So being able to have a pharmacist who can supply ideally blister packs is really helpful. Monitoring a patient, I think, is really the key point for using microdosing, and we'll talk about that in a few minutes. But if you can be in touch with a patient sort of every day is ideal, but every 2 or 3 days, twice a week, something like that, that often leads to a smoother outcome. Next slide, please. So contraindications for buprenorphine. So there really are actually not that many contraindications, particularly in the outpatient setting. So obviously an allergy or hypersensitivity to buprenorphine naloxone or any components is obviously key contraindication. Severe respiratory insufficiency is a contraindication. However, if you're transitioning someone from methadone to Suboxone or to buprenorphine, that's going to be less of an issue because it's going to be have less of a respiratory impact than methadone. Obviously, if people are acutely delirious or acutely intoxicated, then you probably don't want to be doing the transition when that's happening. Severe hepatic impairment, known mechanical gastrointestinal obstruction are contraindications listed in the product monograph. It's talking about a few other sort of acute medical issues, suspected surgical abdomen, severe CNS depression due to head injury are for sure contraindications to making the transition. And taking MAO inhibitors or use within the past 14 days is a contraindication as well. Next slide, please. So we've already talked quite a bit about this in the first slide, but just to review, partial agonists very high affinity. Those are the two really key points. It's important to remember that, and that'll help understand why we've developed this technique called microinduction. So naloxone, as I mentioned, is not bioavailable when taken sublingually. So when buprenorphine preferentially binds to a receptor, it displaces other opioids, leading to an overall lower opioid activation that can cause precipitated withdrawal. So this is the key point that we're trying to avoid. And when you're doing microdosing, this is it's very uncommon to have very significant precipitated withdrawal. It's not that uncommon to have mild precipitated withdrawal, and that's why being able to check in fairly regularly with a patient to sort of adjust the microinduction is often pretty helpful. Next slide, please. So we're going to talk about three methods, but I'm going to mainly focus on the first method, which is the recommended method. The slow-release oral morphine bridge is a method that, from my experience, was actually used more often before microdose induction was around. And I'm interested to hear Annabelle's or others' thoughts on using that now that we're using microinduction. To me, they're actually, it doesn't make that much sense to transition someone to slow-release oral morphine and then to Suboxone, but maybe some people are doing that. When we used to be transitioning from doing a traditional methadone taper, which is the third one there at the bottom, sometimes we had a thought of using, we did use slow-release oral morphine bridges because methadone it takes a long time to titrate someone down and then to start Suboxone. And that's why this traditional method is not recommended anymore. That would basically require us to titrate a patient down to 30 or 40 milligrams of methadone and then have them off methadone for at least 1 and usually 2 or 3 days and then start buprenorphine. This is not a recommended method anymore. And so when we did this, we used to transition someone to Esron first, and then we could stop their Esron and start buprenorphine in the traditional way. So that was helpful. But let's move on to the microdosing. So this is generally done as an outpatient, but it can be done as an inpatient as well, for sure. And it actually can be done much more quickly, doing what's called rapid microdosing as an inpatient. But let's just talk about it as an outpatient. So the key to this is that a patient does not need to be in moderate withdrawal. They do not need to stop their methadone or stop their other opioids and go into withdrawal. So what this does is it greatly reduces the risk of withdrawal that they're going to have leading up to the start of Suboxone. And it's also going to reduce the risk of precipitated withdrawal because we don't require someone to stop all of their opioids to get their other full agonists out of their system. So what we do is maintain patients' dose of methadone while gradually increasing the buprenorphine dose. And generally this is done over roughly 1 week, but for sure it can be extended out to 10 days or 2 weeks or potentially even longer if people are having a really difficult transition. Usually I try and keep it to between 1 and 2 weeks. So at the end of the microdosing, generally the methadone is stopped because the buprenorphine has over 1 to 2 weeks gradually completely replaced the methadone on the opioid receptors. And methadone has a relatively low binding affinity, and so it will be replaced over the transition period with buprenorphine. And as mentioned, transitions can be adjusted based on patient symptoms, which is really important, and this is the recommended method. So let's go to the next slide, please. So here's an example of how to do this over 8 days. And you can see the methadone dose is maintained at its current dose. And so the buprenorphine dose is slowly increased each day. And the idea is that buprenorphine is slowly replacing the methadone off the opioid receptors in someone. And so what precipitated withdrawal is an abrupt removal of all of the methadone off the opioid receptor very quickly. And that's what we don't want. That causes precipitated withdrawal, which people describe as the worst withdrawal they've ever had. It's very severe and it's quite difficult to treat. It's not life-threatening and it's not a permanent problem generally for people, but it is very uncomfortable and we definitely want to avoid that. So this example uses 0.5 milligrams of buprenorphine. It's a bit confusing there, but in the buprenorphine naloxone dose, but you can see the right side is buprenorphine, or the left side is buprenorphine, the right side is naloxone. And so all you really care about is the left side, the buprenorphine dose. So that's the first two are 0.5 milligrams, which is a quarter of a 2 milligram tab, and that's BID and then TID. And then you can see you gradually work up from 0.5 TID, 1 milligram BID, 2 milligrams BID, 2 milligrams QID, 4 milligrams TID, and then 12 milligrams OD. So once you get to about 12 milligrams, somewhere in the range of 10, 12, 14, 16 milligrams, you have a large proportion of your opioid receptors covered with buprenorphine, and then you can just completely stop the methadone. And then on the next day, you're really ramping up. Even on that day that you're stopping the methadone, you're really ramping up. And I often give just people a bunch of 2 milligram tabs and say, keep taking 2 milligram tabs as long as you're slowly feeling better, up to 24 milligrams per day, and then check in with them and see how many they took. Next slide, please. So transition from methadone to Esron before initiating buprenorphine naloxone. Again, this is more if you were going to be doing it stopping all of a sudden. If you didn't have as much time and you were trying to do it quicker, although I don't know how much more time it would save you, you could stop their methadone and convert them all to Esron. And usually then you're on Esron for a few days, and then you can transition to Suboxone. Important to remember that the methadone will stay in your system for at least 5 to 10 days and longer if you're on a higher dose of methadone. So you will have that background of methadone. The downside may require a patient to experience withdrawal or discomfort twice. I mean, there's two transitions, right? And so it's just more of a risk of things not going that smoothly. So I actually generally wouldn't recommend this unless you're not doing the microdosing. Next slide, please. So Esrom to methadone is a ratio of between 1:4 and 1:8. I generally use 1:4 or 1:6 originally as my first conversion, and then often try and give someone PRNs of hydromorph as well too. And then once someone's on Esrom, going from Esrom to buprenorphine, you can either do the microdosing just like we talked about with methadone, and that's what I would actually generally do, is microdose from Esrom to methadone, to Suboxone as well, to buprenorphine. But you can also stop the slow release oral morphine and start buprenorphine naloxone in a more traditional way. If a patient isn't using other opioids, it's a little more reliable than if they are. I would generally wait at least 24 hours. It says wait 17 to 24 hours. I would generally wait at least 24 hours, and generally more like 36 to 48 hours actually off of Esrom is my personal practice, but I'm happy to hear other options. And then starting at 2 milligrams, or even if you're unsure, if you're unsure if someone's ready to start, it never hurts to just start at a bit lower dose. Give them 0.5 milligrams, a quarter of a 2 milligram tab, give that to them and see how they do. An hour or two later, give them another 0.5 milligrams. If they're fine after a couple doses, 2 or 3 doses of 0.5, then give them 2 milligrams. That's usually the way I'm actually starting these days. If I'm starting all on one day, I'm just starting with the lower dose. There isn't really a rush to give them 2 or 4 milligrams right away. But then once you're over the hump of knowing you're not going to have precipitated withdrawal, you can give them quite a bit faster. Give them a bunch of 2 milligram tabs to take home, and then you can titrate up to 12 or 16 on the first day, up to 24 on the second day, depending on patient comfort. Next slide, please. Transition from methadone taper and cessation. Again, I wouldn't recommend this. It's basically just tapering someone down and then stopping methadone for 24 to 72 hours. Generally, it's much longer than 24 hours. You need to stop at least 48 hours and often 72 hours. Some people give a little bit of hydromorph in addition for a couple days and just stop the hydromorph 12 to 24 hours before. And so this would generally be done more in patients on very low doses of methadone already. Also, if they can't tolerate a long taper off methadone, which most people can't, Bottom line is not really recommended to do this, and recommended to ask someone if you're considering it. Next slide, please. Precipitated withdrawal, basically important to warn patients beforehand. This is what could happen. A couple different approaches to this. Generally, if you start to have some precipitated withdrawal, which is generally a lot less if you're doing microdosing, usually you just space out the amount of time that you take between doses, or you wait till the next day, or you go to a lower dose than you had the previous day. And this is what I kind of mean by adjusting the microdose as you go. If you can be checking in every day or every 2 or 3 days with a patient and someone's feeling fine, you can increase their dose a bit faster. If someone's feeling a little bit unwell, or feeling like they're having some precipitated withdrawal, then you slow down on their microdose, and you give them less doses that day, or you wait until they're feeling better before you take a next dose. And so if you have more significant precipitated withdrawal, you usually just ask them to stop, tell them symptoms will resolve as the withdrawal runs its course, give them Tylenol and ibuprofen and other medications to treat them symptomatically. Most important, just to reassure them that it will get better. Next slide, please. Precipitated withdrawal or microdosing. Communication, treatment decisions will depend on the situation. So I already talked about this. Clinicians can slow down the induction schedule, further divide daily doses. You can, as usually a later resort, supplementing with short-acting opioids, like give them a little bit of hydromorph or something. I really try not to stop the induction. I try to just slow it down if at all possible. But in some people, if it gets too bad, then they'll just want to totally abandon the Suboxone. Next slide, please. Take-home doses. The great thing about Suboxone is that's really a buprenorphine. I start take-home doses pretty much right away, as long as as a person is stably housed and they have a safe place to keep their buprenorphine, and I don't think there's a very high risk of them diverting it, trading it, or selling it, or having it stolen. I start carries at least for a few days, almost right away. And while people are on buprenorphine, just monitoring for signs of stability. Even if someone's using opioids or using other substances, I generally continue carry doses just because it's so safe. But I know that's a bit different from clinician to clinician. And the guidelines do say some random urines. To me, I don't do random urines actually in buprenorphine patients, because I'm not going to stop their carries if they have positive urine. So that's being reviewed with the new urine drug guidelines. Next slide. I think we'll skip over some of these because it's sort of getting into carries and stuff, and we're getting a little to the end of our time. Next slide. See if there's any other critical points just to make before. Missed doses. This is the official guidance for missed doses. If you've missed more than 5 days, generally we restart people. If they've been at a high dose, you don't start them all the way at 2 milligrams. If they're on a low dose, you can start them at 2 milligrams. But the more important thing is, have they been using in between their missed doses? If they haven't been using within their missed doses, then you can usually just restart them quite quickly on buprenorphine. If they've been using, and especially if it's been 4 or 5 days or more, then you might have to do a reinitiation. Next slide, please. Urine drug tests, again, urine drug tests are much less important in buprenorphine than in methadone or slow release oral morphine, where you really want to know that people are not using if they're having carry doses. I do, when I see people, if I can, I ask them for urine drug tests just to know what's going on and to educate them on what they're taking, because they often don't know. But according to the guidelines, it's 2 to 4 random tests for take-home doses. Next slide. Just a bit of information about POTS. I think we'll cut it off there because that's about it. I think there's another slide about you can continue the 24/7 addiction line, and that's about it. So thank you very much for everyone.